Hello, today we are going to talk about rules, scores, and criteria that involve your heart. Problems that involve the heart are scary. They are often lethal and almost always things we want to rule out in the emergency department. So it is great that we have evidence-based tools to help us make these decisions. The first tool we're going to talk about is the aptly named HEART score. The HEART score was developed in the emergency department in the setting of all patients with chest pain. This makes it different and more broadly applicable than previous tools and scoring systems that were only validated in patients with acute coronary syndrome. So how does the HEART score work? Well, it has 5 broad categories: history, ECG, age, risk factors, and troponin. Each of those categories has multiple subpoints you can get, ranging from 0 to 2 points. Under history, you can have a highly suspicious history all the way to non-suspicious. If you're highly suspicious, you're going to rack up more points. Your ECG, if you have significant ST depression or signs of ischemia, you get 2 points, all the way down to normal, which gets you 0 points. ECG here is important to note that you have to do this interpretation yourself. So similar to the Wells criteria, this takes a little bit of additional skill and clinical expertise in how you use this tool. For age, you get 2 points if you're greater than or equal to 65, 1 point if you're 45 to 65, and 0 points if you're less than 45. Risk factors, if you have a lot of risk factors, more than 3, you get 2 points. If you have 1 or 2 risk factors, you get 1 point, and if you have no risk factors, you get 0 points. Risk factors here include diabetes, current or recent smoker within 1 month, if you have a history of hypertension or hyperlipidemia, or if you have a family history of coronary artery disease and obesity. The last category is your troponin. This is a lab test, which means it's pretty decisive. If it's greater than or equal to 3 times the normal limit, you get 2 points. If you're between 1 and 3 times the normal limit, you get 1 point. And if you're below if you're less than or equal to the normal limit, you get 0 points. So as you can see, the more points you get, the worse things are looking for you, and the fewer points, the better. And that's reflected in the rates of how your heart is doing in each of these categories. So a score of 0 to 3 gets you a 2.5% MACE, and MACE stands for Major Adverse Cardiac Event Rate. So you have a 2.5% MACE over the next 6 weeks, and that's low enough that this scoring system deems you safe to discharge home. If you have a score of 4 to 6, your rate of MACE is 20.3 over the next 6 weeks, and this is someone who's probably going to get admitted for clinical observation. At our hospital at UAMS, they would probably go to our clinical decision unit, the CDU, under the chest pain or cardiac rule-out criteria. A score of 7 to 10 has a 72.7% chance of major adverse cardiac event over the next 6 weeks. This is really high, so you should begin early invasive strategies. Next up is our friend CHAD, the CHADS2-VAsc score. This is a score that you've probably come in contact with on internal medicine or family medicine, but it's something that definitely pops up in the emergency department too, because patients often present for the first time with AFib in the emergency department. So the CHADS2-VAsc score is a scoring tool that helps you predict the annual stroke risk in patients who have AFib, and with some other criteria involved, can help you decide if they need to be anticoagulated. The thing about CHADS2-VAsc is that the name spells out what the risk factors should be, which makes it a little bit easier to remember. So the C is congestive heart failure, hypertension is the H, age greater than 75 gets you 2 points. That's why sometimes you see a little 2 written as a subscript behind the A. Diabetes, then stroke, TIA, or systemic embolism gets you 2 points. And if you think about it, this makes sense because your annual stroke risk should go up if you've already had a systemic or embolic event. And then vascular disease, age 65 to 74, it has a little bit less risk associated with it than being over 75. And if you are a female, that gets you 1 point. Now, these scores coincide with the annual stroke risk you see on the right. These stroke risks will change based on which resources you use. So this is something you can always go into MD Calc and have this ready for your presentation, because whenever you're talking to your attending about a patient with AFib, this should always be included. You don't want to be asked about this and not have worked it up. So you've been a good medical student, you've calculated what their CHADS-VAsc score is, and now it's time to do something with that information. So you're going to pair their CHADS-VAsc score with anticoagulation guidelines. And this is where there is some subjectivity. If you use the CHEST criteria from 2018, if they have greater than or equal to 1 for males or greater than or equal to 2 for females, then they're going to be anticoagulated. The easier way to remember that for CHEST is they have to have at least one non-sex-based risk factor. Then the American Heart Association increases that to greater than or equal to 2 for males or greater than or equal to 3 for females, meaning at least 2 non-sex risk factors. So this is something that you should think about and probably ask your attendings about at your hospital which one they would consider the starting point. For both of these, the first line is going to be your DOACs over warfarin now. There's evidence that shows these are easier for patients to use and get similar, if not better, outcomes. So your DOACs are going to be first line. The most important thing to remember about anticoagulation is that it has significant risk associated with it. So this is something that you don't just sneak in on a patient and start without a conversation with them about the risks and benefits of anticoagulation, because this is something that you want to have a good relationship with your patient about to discuss, because it is really important that they know all of the risk factors associated with starting one of these. This video is pretty short because you've most likely come in contact with these scoring systems before. Both have level 1 evidence, both are used pretty broadly and occasionally pop up on tests. Less so than some of our other rules, but these are always present in most clinical settings, so you got to know about them. These are the resources I use to learn more and pull these great diagrams from. If you want to get these diagrams for yourself or learn more about any of these topics and do a deeper dive, I encourage you to check these out. As always, thanks for listening.